And so, as probably many of you know, this is the third meeting of the series, um, Hospital Ethnography, a Hospital in Transit, Past, Present, and Future of Hospital Ethnography in the Global Perspective. It is organized within the format of Hospital Ethnography peer meetings, and the peer meetings want to be, first of all, an open space of discussion for different anthropologists, in particularly young scholars. Particularly young scholars, because these meetings are promoted by the MICE network. So the network of young scholars within medical anthropology in Europe. And this wants to be a space of collaboration and of closely collaboration when it comes to different topics that have a very center the hospital in its various forms. So this is the third meeting, and it is the basically this one is the it's one of the closing of the cycle of 4 meetings, and the last one will be the 3rd of November 2023, and it's going to be about hospital collaborations. Whereas today we are going to deal with the viral hospital, and we're going to talk about it in a broader discussion at the end. But today I'm also delighted to introduce 3 thought-provoking ethnographers that will present their case and also their work within these presentations. And the presenter will have 10 minutes. Actually, we are 3 instead of 4, so you're going to have like 12, 15 minutes, so you can be a little bit more relaxed when it comes to time. So take your time, it's not a problem. And we're going to have enough time also for discussion at the end. And we're going to have maybe a short break after the presentations. We're going to have an immediate answer and questions at the very after each presentation. So just to have immediate reactions and to not lose momentum for immediate questions, and then have a broader discussion at the very end. And so that's it. If you have further questions, just ask them now, or just later on during after the presentations. And so I think without waiting further, I'll just leave the floor to Afaluk. Please, you can start your presentation.
Hi, thank you.
If you want.
Can you hear me?
Yeah.
I will now share my desktop. Oops. Please bear with me. Yeah, can you see it?
Yeah, perfectly.
Okay. So thank you very much for giving me this opportunity to present in the series of workshops. And I'd also like to take this opportunity to thank my interlocutors, particularly the farmers working in rice fields in the northeastern part of Thailand that borders Cambodia and Laos, and the local healthcare workers and researchers on melioidosis, and also particularly the healthcare workers in Sapasiti Prasong Hospital, which is a tertiary care health facility where I did my ethnography. Now, in my presentation, you're going to find some long names because they're all Thai names. So I'll try to be as brief as possible on those. I'd like to begin by giving you a bit of a background on this infectious disease, as I assume many of you, like me, before getting interest and doing research in this, I never had heard about it, although I'm from Thailand and I live in Thailand. So it's caused by an environmental bacteria that lives in the soil and water. And it was first identified in Burma by colonial doctors in 1911. It's endemic in Southeast Asia and Northern Australia. And currently, research shows that it's widely present across the world in multiple countries. This disease is a fever-based disease. It mimics TB and pneumonia, and people with sepsis or internal bleeding can have real intense health issues, and it can cause sudden death especially amongst people with underlying conditions like people who have diabetes and thalassemia. The disease is generally transmitted when people are exposed to soil, and it includes inoculation, inhalation, or through eating, food that may have particles of soil or water contaminated with the bacteria. It's also associated with the weather conditions, whereby, like, if there's flooding or during the monsoons, there are a surge of cases of patients in the hospital. Now, the interesting part about this infectious disease at the global level is that it is considered as a biological threat because during World War I, it was researched to be weaponized in several European laboratories. It began in one of the European laboratories, and then there were, all the rival countries started researching about it, because it's a bacteria that can cause infections on humans and animals, but they do not transmit amongst humans or between humans and animals. So that way, during the war, it was researched to kill the horses that were fighting the war. Modeling studies that were conducted in 2015 showed that globally, it's estimated that there are 89,000 people, 89,000 deaths, and over 165,000 infections that take place across the world annually. This disease is generally identified through hospital. So usually people go into hospital when they already have severe conditions. Now, a bit of about melioidosis in Thailand. So this is where Thailand is, in case you don't know where it is on the map of the world. So melioidosis, because its relation with the biological weapon, it was enforced by law to be reported or notified to health authorities since 2017 under the National Communicable Disease Law. And despite this, it's little heard of even amongst healthcare workers, including in the region where it's endemic. Now in 2021, which was the year I did my field work, the Ministry of Public Health issued a national guideline on this disease, but mainly to raise awareness amongst healthcare workers, and particularly amongst healthcare workers working in hospitals, so that they know what to do when patients come and when patients are diagnosed with the disease. The disease is diagnosed through bacteria culture, which takes several days. And in this hospital, Sapasiti Prasong Hospital, where I did my research, majority of the patients' infections reported in Thailand have been reported from this hospital, mainly because there has been decades of research on this disease in that hospital. People can get reinfected and relapse from the disease as well. It's treatable by what they call third level or third class antibiotics. Now, the context of the hospital is this hospital is a tertiary care hospital, so it's mainly a referral hospital for patients to be referred from other places. Most patients come into the hospital when they're already in critical condition, because there's no information about the disease and it's fever-based. So generally people go to other smaller hospitals, and then they're diagnosed with other symptoms like pneumonic symptoms or flu-like symptoms, those kind of things. So that is the context of the hospital. My ethnography, which is where this chapter is based on, is mainly based on a melioidosis clinic that was established as part of the hospital's research. And it was set up between the year 2000 to 2017 for long-term follow-up of patients. Now, research in this hospital began in 1986. So it was the clinic at the OPD was set up years later. So what this this is one of the chapters of my thesis, and what this chapter intends to tell is particularities of this clinic that operated during a particular period of time for a specific reason in this hospital. And the theory that I used to study this work is called Barami, which is a Thai cultural concept. It's affiliated with prestige, power, honor, hierarchy, and it's mainly been studied to look at leadership in the bureaucracy and in politics. So my argument is, in addition to Barami operating at the leadership and the bureaucratic level, I show from this chapter that it is present in the everyday life of people in Thailand and Thai society. And also what I wanted to do with this chapter is to show that hospitals are ambiguous spheres where there is no demarcation, or where there's blurred demarcation between public and private lives, personal and professional spaces as well. Now, in the hospital OPD, the space here is often crowded, and there are generally a lot of people sitting and waiting. They spend, a person who has to come to the OPD in a public hospital like this in Thailand generally spends the whole day in the hospital. And they have to go through a different protocols, from getting the medical, showing their identity card, getting their weight measured, getting their blood pressure measured, going through different desks, meeting different nurses, and then the nurses go into the process of getting the medical records out, and then they interview patients briefly, write down the notes, slip it in the patient file to prepare for the meeting when the patient meets the doctor. So by the time the patient gets to meet the doctor, the patient would have already spent 2-3 hours in the hospital. And mind you, a lot of patients come from far off villages. Some villages are about 100 kilometers or more away from this provincial center. This hospital is run by a doctor who actually began research in this clinic, along with researchers from Bangkok in collaboration with Oxford University, and they're called Mahidol Oxford Tropical Medicine Collaborating Center. So she began this research since 1985, and in the year 2000, when the clinic was operational, she herself ran the clinic once a week with her assistant called Tao, and she was the one who looked at all the patients herself, although by that time she had assumed a senior position in the hospital. Some of the patients who came to the hospital, so usually the patients went through all these protocols and procedures in terms of waiting to be seen by the doctor. By the time they got to be seen by the doctor, it was already half day. And in the afternoons, they had to wait either to get further tests and then to get their medicines. So that way they spent all day. Now, many of the patients who came from provinces that were on the outer skirts, they had to catch the bus to go back to their homes by 4 p.m. Otherwise, they would have had to hire vehicles, which was very expensive. And also because these small pickup trucks that they could hire as vehicles would go, instead of having to pay one way, they would have had to pay 2 ways to go back to the village, and then the empty vehicle would come back into the city. Now, what Tao did was, Tao is the assistant. What she did was to support the patients. She basically offered to provide, to get their drug receipts from them. And she said she would collect medicines from them on their behalf. Now, with Barami of Dr. Vipada, she was able to negotiate with the pharmaceutical department of the hospital. So what she did was she collected those drug receipts from patients. she delivered them to the pharmaceutical department. And by the end of her workday, then she went and picked up those drugs for the patients so that the patients could already leave and get the public transport back home. And then in the following day, the next day, first thing she did in the morning was to go to the post office at 8 o'clock in the morning and post them to the patients. Now, I asked her why she was doing that and whether it was done out of the research funding. And she said she did it out of her own pocket. And it was mainly to make as part of making merit, which is part associated with Buddhist religion and Thai culture also, in the sense that the more merit you make, the more luck and good deeds will come back to you. So she said she didn't do it for everyone. She mainly did it for people who were the elderly and people who had to who did not have public transport or did not have people who came in from the same village. And although she was able to do this, she was able to do this in a continuous basis that it brought her a bit of popularity amongst the hospital staff, because she was part of the research project's staff. The nurses in the hospital during my fieldwork in 2021 still spoke about this when they heard that I was researching on melioidosis. They told me that, they kept talking about Tao, and they said, she was very popular and she received gifts from patients when they came in. They brought her as a gesture to show their appreciation for her small products from the local village that they grew, which is fruit, vegetables, or grains of rice, just to show that they appreciated her. And she would also, share those with some of the nurses who helped at the clinic. Now, the hospital staff spoke really highly of her, and it actually reflects on her barami in this regard. So in conclusion, what I argued is that Dr. Vipada's barami made Tao be able to get access and negotiate for the drugs on behalf of the patients from the pharmacy department, because that was generally not really allowed. And but it is with Tao's barami that the melioidosis clinic was able to collect data for more than a decade to research on melioidosis, because she was the one who had good contacts and relations with the patients. So the material exchanges which involve drug receipts, village produces, and the Buddhist belief of merit making mediated the production of knowledge on melioidosis in Thailand. And yeah, I'm happy to answer any of your questions. Thank you.
Thank you so much. That was really, really interesting. And so we will have a short question and answer session and then a final discussion at the end. So do you have immediate reactions or comments or questions for have a look?
I have a question.
Yep.
Thank you for thank you for your presentation. And bear with me if I somehow missed it in the beginning, but you mentioned when you gave an overview of your presentation and the kind of context of the condition, how it is mostly rice farmers who are affected. And for me and you mentioned then that the condition was also very prevalent in this particular clinic, explaining how, or giving the explanation that this is due to the research that was very much driven in this particular context. I would be curious to hear more about the link between the population that is mostly affected and the clinic, so more the socioeconomic reasoning of how it is a particular population is mostly affected by the disease.
Thanks. So basically, this whole region, northeastern region of Thailand, is rice farming region, and Thailand is one of the largest rice producers in the world. Now, the reason why this particular hospital saw a lot of patients who were farmers also is because a lot of people in this region or in this province are rice farmers. Recent research has shown that, the disease, the bacteria is in multiple parts of the world. And like, for example, I think it was in the beginning of 2022, last year, or the end of 2021, in the US, it was reported for the first time that they found the bacteria in the soil in southern Mississippi River. So there was a whole hoo-ha about it. And then usually they know about this disease and they associate it with travelers coming from Southeast Asia or from Australia, etc. Yeah.
Thank you.
Are there any other questions? And I'll just jump into the discussion, ask a question myself. I was really curious about, thank you so much for this very interesting talk. And I was thinking about the relation you described between melioidosis research, the disease, and these exchanges that actually contributed into financing the, both the clinic, but also the research about the melioidosis. And I was curious about, like, if you could elaborate about, was this necessary because of the lack of general funding, or was this necessary to create a trusting relationship with the local population that was, using the clinic, or was this so why, what did you find out when this relationship started and how it evolved, and why was it necessary, or was something that simply evolved by itself? If you could just elaborate more on that.
Yeah. So the data was collected retrospectively because my research took place in 2021, my field work. And what I heard was that this melioidosis is well-funded because it's a collaboration between one of the prestigious universities in Thailand, a medical university, and Oxford University. And it's always received regular research funding particularly from Wellcome Trust. Now, the issue that Tao did was mainly out of her own interest in terms of Buddhist belief to be doing something good so that it would give her a sense of goodness back in, it would make her feel good that she's making merits, or what we call tambun in Thai. And it's quite popular, like it's a regular thing that people make merits. And if you make merits with people who have a suffering, like in terms of health or in terms of the poverty, it makes people feel better. Another thing that we could associate is, like in Thailand, whenever there is any kind of need in terms of anything, in terms when there's a disaster, when there's floods, or even during COVID, it was mostly the people, general population, even if they were not rich, went out to provide donations and volunteerism. So that's part of the Buddhist culture and belief that brought in. Yeah.
Okay, thank you so much for this. And it's very interesting that there wasn't like a dire need for funding, but at the same time, this is actually something that evolved. And I was wondering, like, just out of curiosity on this same topic, did this also going along with the Buddhist belief helped in reaching out to the population, or reaching out to people that were more willingly coming to the clinic itself, or trust more the healthcare authorities? So it created a sort of a relationship, or?
So generally, there is a level of trust amongst local healthcare workers and the local community in Thailand, because it dates back. Hospitals were expanded throughout the country up to the sub-district level. as part of nationalism. So because of the history of politics that spread out healthcare, they have established good relations, better. The relationship between healthcare workers is much better than any other bureaucratic institution in the country with the local population. Now, in the beginning, when they wanted to follow up, there was a bit of a challenge in getting patients to come into the hospital, because a lot of patients, when they recover, they don't want to come back. But it's because of the friendly attitude and gesture that it facilitated patients coming back into the hospital, even though they felt that they were already all right. And this is associated also with melioidosis treatment, because there are two sections in the treatment. One is the acute phase, where patients are given intravenous antibiotics, and then the eradication, the bacteria eradication phase takes up to 5 months of treatment. So by that time, patients would already feel good, and they would already think that they've already, recovered and all that. And interestingly, there's no such programs as the DOTS for tuberculosis, where they follow up on giving antibiotics to patients. Yeah.
Okay, thank you very much. And are there any other questions? Okay.
Hello, am I audible?
Yeah, go ahead.
Hi, thank you, Mirko, and thank you, Aflak, for this session. I'm interested to know more about what sort of distribution we see across male and female, because both the set of people might be contributing while we talk about rice farming. So what sort of distribution in prevalence we see in melioidosis across in Northeast Thailand?
So according to the data that I looked at, which was like 2016, 17, 18, there was slightly a bit more of the male population than female, but not significantly different, because most farming is done by both males and females. And also, just to let you know that it's not just in rice fields as earlier understood, but it's in widespread agricultural areas, or even in places where there's flooding and where there is natural soil, which is not cemented.
What sort of comorbidities that we see majorly apart from diabetes and thalassemia?
Well, these were the two that were mentioned in the medical literature. So I cannot comment on
Thank
the
you so much. Yeah, thank you so much.
Thank you.
Thank you all. So, okay, I think we have to move on, and I'll just invite Julia to take the floor.
Yes, thank you. I'll share my screen. 1 minute. So you should be able to see my slide. Yeah, okay. So as you mentioned in the beginning that the 4th workshop will be on collaborations, I was wondering whether I would be more fit to be the part of that one, but nonetheless my presentation touches upon or is very much around the COVID-19 pandemic. So yeah, it fits in either workshop. So my name is Julia Reesman, and I'm at the moment a postdoc or senior researcher at the Bern University of Applied Sciences, but I'm a social anthropologist and have been now more and more engaged in collaborative work and interdisciplinary projects with designers or with medical historians than I previously have at the University of Bern. So today I want to give an insight in a project that was very, for me, more or less a testing ground in interdisciplinary research with a designer, also a very quick ethnographic approach, and also laid the groundwork for a project proposal that I've recently submitted together also with Janina Kerr and Sabine Strasser from the University of Bern, which centers on the idea of the hospital as a global site, where a local site where the global influences have become very tangible and play out very distinctively. So the talk today is called The Global Hospital in Pandemic Times, and is very much about the collaboration between medical anthropology and design. And the project I want to talk about is called Pandemic Objects in Practice, and was was particular in a way that it was an applied research. So the medical collection at the Inselspital in Bern, which is the university hospital here in Bern and one of the bigger hospitals in Switzerland, approached my research group that they had like some funding and wanted to do like a special exhibit and a project on the pandemic with a very open format, with a very limited budget, and a very quite open for suggestions how we would frame or shape that project. So the medical collection in Bern is not an on-site museum, not yet. It is a digital museum. So they have an on-site collection of historical objects, but they don't have an on-site museum because of budget reasons. So what they have is a digital museum to which me and Laura Hensler, designer, were asked to contribute with a special exhibit, something that I haven't done before. And the idea was how to tease out how the COVID-19 pandemic affected everyday working life in the hospital. And as the medical collection is interested in objects also collecting objects and the stories behind those objects, what kind of objects were improvised with, which ones turned out to be obsolete, which ones were given new meanings, and kind of record the practices and stories behind those objects. And with a very rapid design ethnographic appraisal, we collected objects and stories to create a special exhibit. So this was us. And it was also, for the first time, a collaboration between the two of us. Sorry, this is not a bit. So the timeline of the project was very much in line with everyday life in the hospital during the time. So the planned start was for October 2020. So in the midst of the second wave of the pandemic over here in Switzerland and I think across Europe. And it was repeatedly postponed by the clinic due to pandemic and lockdown measures and visitor restrictions. So their argument was that as long as like family members can't visit freely, why should researchers have access to the clinic? So we then started actually more or less almost 2 years later, had like field research planned for like October, November, December. Then another postponement happened because I broke my leg like a year ago. And so, very much, I think for me, that was quite symbolic of the whole pandemic in a way that you had to postpone, you had to like rearrange, reschedule, have to be open for also short minute changes. And so there are certain kind of attempts to tell the crisis or tell about the pandemic through everyday projects. So this is not a new idea. The Victoria and Albert Museum have a very beautiful collection of pandemic objects. And the Vienna Museum in Vienna have a less vast collection, but they also attempted to get in the midst of pandemic objects. But what hasn't been done yet was like with a particular focus on clinical, like in a clinical context. So this is where we kind of set out to delve in. Things that came up before, like when you're doing research and working also, I think in anthropology, there have been also publications on, for example, the cuddle curtain that is mentioned here that allowed people to kind of experience like intimacy, or like was a tool or an object to facilitate intimacy during visitor restrictions and lockdown measures. Then it was called Hand of God, the kind of glove that was filled with warm water to imitate human touch. And of course, masks are very obvious, omnipresent pandemic object that kind of might come up. So what did we do? And I think this is for me also very telling of anthropological projects and also interdisciplinary ones. So we had came up with a very open online survey that we kind of used as a tool to educate and inform hospital staff that there was a project that would be would be done in the clinic. Also with the idea that people might want to share their stories without wanting to be interviewed, or that we might, due to the limited budget and the very restricted time frame, we won't be able to kind of talk to everyone who would be an interesting interview partner. So we were like to maybe include as many people as possible. We also started an online survey to which we got exactly 0 replies. So nada. Nothing came out of the online survey. I wasn't really sad about that. I think, you also have to do something with the data, and we were also happy to not have to open this box. But we had an online survey that was more or less, didn't lead to anything in particular. So what did lead to a lot and more than we had initially planned were 5 days of kind of field research at different sites in the clinic. And here we approached the clinic not just as the hospital, not just a clinical space or a space of medicine, but very much inspired also by Fanny Chabrol and Janina Care as a hospital multiple, or a hospital as a modern medical space that involves also infrastructure, for example. And we had like an idea of including equally clinics and infrastructure departments in our during the research days. So we had like an emergency unit, pathology, pneumology, obstetrics in mind, and also access to those, or trying to get access to those clinics. And then we had the carpentry, hospital pharmacy, facility services, and laundry services, where we thought we wanted to, do interviews, observations, whatever might happen during those research days. So the idea was to have like those 8 interviews, wards, and that kind of with a very classical snowballing effect escalated very quickly, that we had way more interest interviews than we had initially planned, with a limited budget and time frame that also posed certain challenges. But was also really beautiful to see how we got kind of referred to other people, that the whole idea of getting to, as soon as you have your foot somewhere, and as soon as you get to into a clinic, into a site, people kind of transfer you to other and refer you to other people you have to talk to. And so we had way more sites and interviews than we had initially planned. And the benefit or the challenging and beautiful thing of collaborating with a designer was that she had the idea to build a research card that we use as a tool to facilitate, on the one hand, conversation, but also inform people that we are there on this particular day, to also use as a kind of background for the photographs we had planned to take, and as a maybe tool during an exhibition to kind of present pandemic objects. So she planned, she built, and she painted, which resulted in a research card that drove around the hospital in underground corridors, found its way to the carpentry, and was also photographed in the studio, but had also its pitfalls because it was too high and too broad for certain corridors. So Laura had the idea, I will like plan an object that is smaller or this not bigger the size of a hospital bed. So there won't be any, so yeah, it will be easy to kind of move around the hospital, but a lot of infrastructure and underground sites don't have these measurements. So a lot of corridors weren't accessible to us with the cart due to its size. So at some point we were like, okay, let's just leave it be and we won't move it around. We just leave it in the carpentry, and you and I will go to the interviews, to the scheduled meetings together. Where usually I was the one conducting the interviews, and she, as a designer, was sitting next to, sitting at the table, connecting or like grasping or grabbing onto certain notions and ideas and usually objects that people mentioned, and having like follow-up questions around those. So something that might will pop up later on during an interview with the emergency unit with the cleaning services, they mentioned pizza boxes, like for takeout pizza, that they had a lot more to do, and the cleaners were challenged because of the access in takeout dishes and boxes during the pandemic, because people had to have the lunches in their offices, if possible. So something that I completely overheard and didn't really notice was the mentioning of the pizza boxes. And she was like, oh, those pizza boxes, this is so interesting. So how someone with a different background, but also a second pair of ears might add, just another perspective on the research, but also just hears different things, and that might prove very inspiring and fruitful later on. So this was the card that started the thing, and then was kind of put to bed in the carpentry. So examples of pandemic objects that we kind of collected was, on the one hand, maybe I have to quickly say one thing. So we had the idea to collect objects. That proved also very tricky, because a lot of the things that people talked about were not connected to objects, or we invited them, so please bring your object, we will be around. And yeah, we had a very limited amount of objects that we could actually, like tangible objects. We had a lot of information leaflets. We had like the schedule of particular wards, like how team meetings were organized. We had So a lot of paper objects, but not really tangible, nice to exhibit and present objects. So one of the more like tangible objects, on the one hand, a Dropbox that was improvised by the central warehouse Department for Transport and Logistics, which was for the COVID testing, the Dropbox of the nasal, of the fluid, that you have to collect for the testing. And the kind of story behind the box is that usually it is used for a particular waste collection. And during the pandemic, due to the shortage of all of supply chains were kind of cut off. It was very hard to find certain things online, like also medical supplies were very hard to get. And this Dropbox was an example of improvisation, of very low key adapting of a box that was actually meant for something else. And the kind of warehouse workers were cutting like an opening into it, adding like a lock so it couldn't be opened. And that was in use in like several sites of this hospital. And was kind of the alternative to a very high-end, very expensive other options that were for sale in through medical suppliers. Another object that we got was like a sticker, enjoy only here, or also like think only here, that was used in the library to kind of enforce seating restrictions. So on tables, there were stickers that you're only allowed to sit here. Or in the library, you're only allowed to kind of think here or read here. That was enforced by the hospitality department. And one of the surprises that we had, or one of the also big surprises that I had, was in the laundry service and workwear department, where I expected a kind of story of just more workload due to maybe infected bed sheets, workwear, and so on. So what the pandemic actually it facilitated there was a shift back and a return to reusable clothing. So in Swiss hospitals, I don't know how it is elsewhere, but there was a trend for like 10 years now to use paper clothing, particularly in surgery. So in the surgical theaters, you use paper and just one, how do you say that? Disposable clothing due to hygienic reasons. And that was also it was not possible to get hands on disposable clothing anymore. So the supply chains for that were interrupted through, where on the one hand, where the garments or the paper is produced, on the other hand, where it gets made and then shipped from. And the head of the workwear department was very much in favor of reusable clothing, but didn't have the kind of arguments for that. And so the pandemic and the kind of interruption of supply kind of facilitated this shift back to reusable clothing. And there was a whole story also around what kind of fabrics you are supposed to use in surgery, what are considered hygienic enough, also what kind of colors you're allowed to use, and how you kind of discuss those kind of issues also with surgeons who kind of are very much opposed to like wearing white in the theater. So this was also like one of the pandemic objects we got, and what kind of like an answer to the lack of objects were then kind of the use of illustrations, that the the collaboration with the designer made possible, because I can't do stuff like that. So as I mentioned, the example with the pizza box was something that Laura then thought, this is something we could illustrate with a pizza box, or for also the shortage of certain heads of razors that are used also for surgery. So they had to kind of think about potential solutions if they and alternatives for the particular razors they use for surgeries if they won't get their hands on them anymore due to also supply chain shortages. So the disposable razor became also a symbol of this search for alternatives and the improvisation that is needed during or was needed during the pandemic. Or a parking ticket here that showed how a hospital only, so the visiting, the lockdown measures had the effect that the public transport was not working anymore, and people had to get to work somehow who are working in clinics, and how to kind of come up with parking spots in a city that is very limited in parking spots for the hospital workers who nonetheless have to come to work, who usually rely very much on a public transport system. So this is, for example, something the facility services had to supply in a very short time. So what we came up with, and at this point it is still only in German, is like also our own visual representation of this special exhibit on how like medicine is made in pandemic times, and using illustrations side to side with actual, for example, here PDFs of duty rosters in obstetrics and the quotes from interviews, and also always also playing like asking for participants' feedback. So a lot of our interview partners also contributed with their images, like their pictures they took, for example, of warehouses that were overstacked. Yes, I have no idea how much time regarding time, so I can talk like for ages about these stories, but I won't at this point. I try to kind of give some concluding remarks or conclusions that came out of the project. On the one hand, for me, one of the big takeaways was the benefits, but also kind of the risk or challenges of working interdisciplinary and working also with designers. The kind of more visual language that is used to illustrate also very complex issues was one of the very inspiring aspects of it. So for example, the pizza box is for me something that illustrates, on the one hand, isolation during the pandemic, on the other hand, also the extensive workload that and in like acceleration of workload also for cleaning staff who had their own, who were under immense pressures by also other physicians, team members, because during the pandemic everyone was kind of, or a lot of people were also freaking out about infections, so they wanted to have everything very clean, their own work desks and so on, and this is also just not possible with a limited amount of staff and also staff who is falling sick. So the whole collaboration would be one thing that for me was a very take home thing that I want to kind of delve into deeper in the future. During the kind of information phase of the project, there was a lot of irritation also over terminology. So we started, as I said, like in 2022, when in Switzerland, there was a lot of opening up. So the pandemic was more or less over in the public eye, but for the clinics, the pandemic was very much, or COVID-19 was very much still going on. So the discrepancy between kind of the public perception and the perception of the clinic and the hospital workers, whether a pandemic is actually post-pandemic or still very much still going on. Then, as I mentioned, also there was no response to the online survey, the kind of detour via illustrations. Then also very, we could, we didn't delve deeper yet into like analytically what would be possible, I think, with the data and material we gathered. Very generalistic how the pandemic works on the one hand, also as a catalyst for innovation and new things to kind of come up with. On the one thing that was the return to reusable clothing, but also other things that got really pushed due to the pandemic, particularly in pathology. And on the one hand, how it's just a burning glass for existing inequalities, like for example, a lot of communication was done during through digital and online tools and means. So intranets at the clinic, but a vast majority of staff doesn't have access to the intranet. So cleaning staff in the hospitality, which are also mostly non-Swiss citizens and have also not German or Swiss German as their mother language or first language. They don't have access to the means through which the clinic actually communicated its most important information. So how to find ways to kind of include as many people as possible in kind of information distribution was one of the things that I kind of stuck with me. Fleeting solidarity and frustration was one of the things that came up consistently through all departments and wards, and regardless of clinic or infrastructure side. Yes, and this is was very strong in the Swiss society, which has a very emphasizes individual freedom alongside individual responsibility very strongly, is how like mandatory testing, mandatory vaccination caused very much a rift in society as it did in the clinic. And something that still reverberates somehow. And I will end here.
Thank you very much, Julia, for a very interesting talk. And so, do you have immediate reactions and questions? Okay.
Hi, Julia.
Yeah, you go ahead.
I have
Go
one.
ahead.
Yeah. So, research cart looks really interesting to me, with the prospect of using it in the hospital. And I just wanted to know, like, what was the people's reaction towards the card and the way it was used. I just want to know more about it. Like, does it included some sort of educational material, or was it used to collect the objects, only the objects, and there wasn't any educational material for people to see, observe, and react to it?
So also how the card was used. Did I understand you correctly?
Yes.
Yeah.
Yes.
So the card was it had we used it as a during our days there. We used it and we only used it, I have to look that up, I think on 2 out of 5 days, because then it just proved it was on the one hand too big to be transferred easily from one side to the next. And on the other hand, it was kind of November, December. It was snowy and slippery and not made for a lot of traveling. And we used it on the one hand in the carpentry as one of the pictures illustrated as a desk. So we had interviews on the cart, like at the cart. We also used it as a tool to kind of put during our lunch break, for example. We put it in front of the cafeteria. We had our flyers there. People were looking at it strangely, but nobody kind of asked questions. And but the kind of glances and looks we got while we were kind of driving around in the clinic, that was quite interesting. But the tendency that everyone is looking, but nobody's really asking. And we didn't, we tried with using it as a background for the photographs, but due to the fact that our idea of having people come to us and bringing objects, and which we would then take pictures of, did not work out as planned. We use it as a background. We tried to take pictures, but those were just poor quality, and so we kind of decided that those had to be done in the studio by the photographer of the medical collection, so the objects have a nice look and just don't look very dim with dim light and in some corridor. So the cart was, for me, a really nice idea that is an example of you don't think things fully through, and then in real life, in the setting, you just like experience the limits of a really nice idea when when it's just too big to access a corridor or too tall.
Thank you so much for that response, because the idea of a research card in the viewpoint of a healthcare facility sounds really interesting as per the design point of view, because I'm also included in the healthcare space as of now, and where I kind of work around designing educational material or IEC material for people, basically patients and their caregivers. So sounds really interesting to me. I just wanted to delve deeper into how people usually behave around these sort of things, and whether they really whether they really sort of look like curious to know more about things happening around their particular environment. So thank you so much for that.
Thank you.
Hi, thanks, Julia. It's really interesting. I had a question on whether you were able to. So there are two questions. First is, you said you sometimes were stationed in particular places in different parts of the hospital, and healthcare workers came in. I was wondering if you had access issues to any of the specific places, and what was the reason given? And the second question is about the waste, the drop box that you mentioned. Were you able to also look into the garbage bins around anywhere in any space in the hospital? Thanks.
So the question of accessibility and how did we actually get access to those sites. So what the initial idea was to become stationed at one side and just stay there and observe, also follow more participant observatory approach to also observe what is going on and have people come to us. That we didn't do that. We very early on were asked to make appointments with nurses, with physicians, also with people who are working in infrastructure. So the whole idea of just being there and seeing what happened got very much thrown out of the window very quickly, and we had scheduled meetings with and interviews with different sites. And the access, the benefit or the advantage of this project was that it was like in a collaboration with the medical collection that is like a linkage between the university hospital and the University of Bern, the Medical Historical Institute there. So they have the head of the collection is also part of the medical university, who gave us and so we got easier access. We had like the okay from the medical director of the clinic to do our research. And so with that more or less very informal okay, we were just very boldly making our way through the clinic and just referring to him and to the people we got the okay from. So we had no forms. We had the information leaflets, but that was more or less it. But of course, we had that very much allowed the access in the first place, to have this kind of link through the medical collection.
Interesting. And this was during the pandemic?
That was, yeah, but not during the heat of the pandemic. So that was the thing. We wanted to start during the heat of the pandemic, if you want so, but then it got postponed. So, which for me was also interesting to reflect upon. What kind of phase are we now in actually, and what kind of phases did we go through, and how did the clinic react during different stages to the pandemic, and what were the kind of themes and topics that people were just engaged in and yeah, trying to make do. That was very different also before the vaccination was around, and then after the vaccination, the whole discussion and the kind of rift that happened in the clinic. Yeah, so different phases. So even talking about what did the pandemic do, like about what kind of time frame are you talking about, and which kind of phase are you talking about? And the other question was about the
waste.
help me again. About the waste. We wanted to so we only got to the cleaners, and I really wanted to, there are certain sites I wanted to access, and we didn't get any reply. So the waste collection was something that yeah, we wanted to include and weren't able to include. The other site I really wanted to include was the hospital pharmacy. Didn't get any reply for my emails or calls. So yeah, that was just something I tried really hard and couldn't contact them. And so yeah, waste, no, I did not look into waste bins. But yeah, the whole how the pandemic affected waste collection and what kind of waste is produced, and how this also affects the environment is a whole other issue that also illustrates very beautifully how the clinics and hospitals contribute to, are also connected to the environment and to, yeah, their surroundings.
Lucia, go ahead.
Yeah, thanks for this really interesting presentation. So I was wondering, and maybe I missed it, but maybe you could talk a little bit about the actual exhibition. So from what I understood, it was, so your pandemic objects were exhibited or are being exhibited now. And I was wondering whether you could talk a little bit about that, and who maybe it is now interesting for or isn't, and who's actually going and coming to the exhibition, because I think this is always so interesting. And I think I heard this discussion also in another medical museum, sorry, I don't know the English term, where we were also talking about, okay, will anybody actually look at this now already, or do we have to wait 5 years for people to, you know, be interested in and also emotionally maybe ready for actually, you know, dealing with the pandemic or encountering the pandemic in this museum setting, and in the setting especially of like historically, you know, historical medical museums. So maybe you could talk a little bit about this whole part of what is actually now happening with the exhibition.
Yeah. So for us, the challenge was to plan, like the digital museum, like the exhibition was planned for digital museums. So it was the thing that is published now is the digital museum, the special exhibit on the website. The objects, like certain objects, have become part of the medical collection, but as there is not like an on-site museum that you can just go to and has opening hours, regular opening hours. They are only open during very special like events, like museum nights that are like annually. But what we did do was have an opening, like a vernissage, like an opening of the exhibition with an on-site satellite. So here, very in walking distance to the clinic, also at a kind of to the university hospital, we had like a 4 or 5 pandemic objects. I didn't include a picture of that. That's true. We had like a monthly, like a 1 month exhibition on site where we had like the cart was there exhibited. We had like iPads that were so people could access also the online exhibition, and pandemic objects like the box or the stickers or a sign or also the clothing, the reusable workwear. So there was like an on-site satellite, and during the opening I included the people who contributed, like interview partners. So it was not me who gave a presentation, but I gave a very short input about the project, and then had the people tell their stories about the pandemic and have their voices represented during the opening. Which, yeah, on the one hand you have to curate who is actually also a good fit for an opening and willing and also to talk in front of an audience. And my experience was that, and for me it was also important to include nursing staff and not just like the head of obstetrics or the head of the emergency department, but also have people who are usually not so visible when people talk about the pandemic. And yeah, I think my experience here was that people prefer to forget, and not also how quickly. I think that's also like a hard truth for a lot of people in the clinic, that there was so much, on the one hand solidarity, there was clapping, there was this whole emphasis on in German it's systemrelevant, like system workers who are relevant to keep the system running. So teachers, nurses, kindergarten teachers, and now it's like no effect that was long lasting, however. So even cleaners are now, again, the discussion is about outsourcing those departments, which were only possible to work during the pandemic because they were not outsourced. So I think there's a lot of frustration, and also I think it's very frustrating how short-term the appreciation of certain jobs are, and how the kind of aim to kind of economically or like the kind of outsourcing trend is still going hard despite the experience of the pandemic.
Yeah, that's very true. Thank you. That was interesting.
Thank you so much, Julia. And do you have other questions? Otherwise, I think I could actually, I have at least 5 questions, but I will not ask all of them because it's really, really interesting. And I think one of the things that struck me the most is actually the pizza boxes. I actually have the opposite experience in the ER when I have been working. And so I have been doing my fieldwork within an emergency room in Italy, in northern Italy. And of course, that was before the pandemic, but of course, I stayed in contact throughout the pandemic with them while they were. And I also had contact with people working in other hospitals, both in ICUs and emergency rooms. And what was interesting there is that the card boxes for the people that you interviewed, signify the fact of having, kind of a lonely life, not having time to cook a proper meal. You have to just kind of stay there with cardboard boxes and then not being able to actually take care of your own lunch or dinner time because you have to work and you have to be isolated. You don't have to clean the dishes and so on and so forth. For the people that I spoke with and so on and so forth, the pizza boxes actually developed as a sort of a gift economy in the sense that local pizza places actually gifted pizza all the time to the ER doctors or the ICU people. So there was this, actually there was kind of challenges between different pizza places to actually make the best pizza for the ICU people. And they actually were deciding which place was actually kind of the best. So it was weird because it became, and of course that was always in local newspapers because everybody was talking about the pandemic. So the hospital kind of became a showcase of kind of the best pizza in the city in that sense, because it's the one that ICU people get, so that must be the best. And so it's ICU approved pizza, which is weird enough in that sense. And what it was interesting there is also that so one of the things that they talked to me about is that the problem with the pizza boxes, for instance, is the fact that they couldn't really share as they used to do the meals, but also the shared spaces like a kitchen of the ward. So you weren't allowed to be staying there in the kitchen all together because they would cook meals. And when I was in the fieldwork, I would be also cooking with them all the time. And they would really go for very big meals, and people would take charge of I don't know, cooking a couscous or cooking rice, making a lasagna for all the people that were going through the shift in that same night. And these things could not happen during the pandemic time because you share too much time within the same small room while you eat, so you don't have any kind of personal protection equipment. That was the narrative for them. So like the pizza signified solidarity from the outside inside, and in some sense like the hospital became a showcase, but at the same time also it was because they actually were relying from people on the outside to actually survive what was going on inside. So there was like this mutualist change, which I think is something that very close to what Afalo kind of described when it comes to these kind of exchanges that maintain the clinic running in some way. And it was interesting how different that might be. And another thing that it struck me really that maybe you didn't encounter them, I mean, in Italy they became particularly famous. There were Decathlon sub masks used for ICU ventilation. Have you ever encountered this? No.
No.
So
What kind of? Yeah.
So basically, like the sub mask, the usual normal sub mask that you can buy wherever in Decathlon. So like they are kind of the official particular ones. They're both used, like they modify them in order to be used to make like high pressure ventilation in ICUs. And they have been proven effective. So there is actually articles and research about this. So there was a moment in time in Italy where you couldn't find ICU ventilation. So they used, so Decathlon like shipped a lot of this sub-masks, and they were used both for personal protection equipment and, because I couldn't find personal protection equipment, and also for high-intensive respirators. So that was also very interesting because, and then it became a showcase for Decathlon to say, oh, we support these people in their struggle. So we are, as you said, like societally relevant. So this is not just, for sports and so on and so forth, which you could not do because, it's pandemic times, but then, it's also for societal relevance. So we actually make masks. So it was interesting to see like how the whole practice around objects actually shifted and how the hospital became a showcase for the outside to get inside and then get kind of a sort of a echo chamber of some sort in a mediatic way. So I wonder if you kind of had a similar encounters of some object used for mediatic purposes or advertisement, but also solidarity purposes.
Yeah, I think and I assume your field work is in Italian emergency wards.
Yeah.
So
Yeah.
your pizza boxes are like the chocolate boxes in Switzerland.
Okay, interesting. Okay, interesting.
So I think, yeah, so the emergency units were like drowning in chocolate.
Okay.
So I think there's a parallel there. I have to think more thoroughly about whether I encountered certain companies that were able to make use of the pandemic for public purposes. I'm sure there are certain things going on there, but not as drastically as you mentioned it. It might be that there was like the university hospital here had already like a pandemic, like they had already like a pandemic plan in place and had certain, they had masks and certain gear, like protective gear that parts of it they were able to use, parts of it they was completely useless, like the full head-on gear that was used during Ebola was just didn't prove usable. But yeah, I have to think about that. And about the because you said that you did your fieldwork in the emergency unit. For me, also one of the interesting kind of like narratives or stories that I encountered, or facts, that how the emergency unit became also how they had to deal with a lot of Vergiftungen, a lot of people who got intoxicated, because they were using recreational drugs that they were not used to, and because the supply for also clean drugs were cut off because the borders are closed. So a lot of drugs were, not clean, and so they had a lot of way more people administered due to toxicity reasons than and before the pandemic. So that was one thing that I also, for me, illustrated very beautifully the effects the kind of the closed borders, lockdown measures have in hospitals that you don't expect on a first glance. So yeah.
Thank you for that. It's very interesting, and just very very quick follow-up comment. I was wondering if you encountered also like this sharp division between dirty and clean things, in the sense that you always have, like during the pandemic times at least, in any hospital, I think this occurred, they divided spaces between dirty spaces and clean spaces, in the sense that there were some spaces in which you had to had a full gear equipment of personal protection equipment, another space in which you were allowed just to wear a face mask, and you couldn't bring anything from dirty space to the clean space. So you had to get dressed between these kind of spaces. And in Italy, for instance, like they have been using like red and white tapes or different planning and plans to kind of plan ahead and divide in a planned way the different spaces in order to actually let people know which spaces were walkable through, which others instead you would have to have full equipment. And I was wondering if you had some objects where we're kind of representing this kind of strong division between dirty and clean hospitals and the different kind of areas that were strikingly divided in a different way from from the way hospitals are used to be divided, which is usually according to disease instead of according to being clean of the virus or dirty of the virus.
Not so much, I think, as you encountered in Italy, and also my family is in Austria. How I encountered through the narratives in Austrian clinics and hospitals. So Switzerland had a very low, so it was very low in public measures to protect, like of protection. So also depending, like face masks were not the FFP2 mask, not the safer ones that were around. Like clinics didn't really use them except when you're really in contact with an infectious person. In other parts, you had the regular ones. In Austrian hospitals, they even in the public transport outside, those kind of the more safer masks were used. So Switzerland for me was very particular in its very low-key approach to limit infections, safety. How the rationales behind that are is on the one hand also scientific reasoning and research, on the other hand also what we have in the warehouses and kind of what kind of supplies can we get. And how, like, regarding planning, I had an interview with the person responsible, with two people who are very much responsible to plan for pandemic or for emergency situations and pandemic contexts. And they had a full-on plan also how to behave when an influenza pandemic is gonna hit the clinic, because that's what they were expecting. And so they had an idea of where corridors will be, like the kind of signaling of where patients who might be infectious should go, and it was all inside. And then during the COVID-19, and as soon as kind of the first information came out how the disease is transferred from one patient to the next, they very much saw that all the planning was for the waste bin, because the kind of parameters they kind of planned on were just not holding for, didn't fit to COVID. So what they did a lot of stuff just happened outside. They built tents, they kind of reused parking spaces to kind of have the whole COVID crowd outside and the whole testing outside in regard to safe and clean and unclean, and not inside the hospital. But no, the kind of the maybe if I would have done the research during the heat of the pandemic, but yeah, one like last year, not so much. That was not the most pressing issues people talked about.
Okay, thank you so much. And are there any other questions? And it is, of course, we have already dived into a plenty discussion. So the question can be both to Afaluk or to Julia.
if there are no questions yet, I'll just
Yep.
add a bit on the access to space that I was asking Julia earlier on. So I did my field work in this regional hospital in Thailand during COVID, and there was Thailand was really strict with their lockdown, and they limited access to people in the hospital. So my access was postponed several times, but after getting ethics clearance, I got access into the hospital. But the interesting part is that, you know, different hospital spaces were controlled by different professionals. So to access the outpatient department, I had to contact the nurses department to ask them if I could, you know, do my ethnography and go and have an observation there, and then request for interviews with the nurses. But for the inpatient department, it was the doctors responsible for those different wards. So there was some interesting dynamics in how they divide the spaces between doctors and nurses for that. Yeah, just wanted to share.
I think maybe this is something that I think is very telling of how also people very often assume that if you like that it's doctors working in a clinical ward, and usually they aren't. You know, like usually it's nurses who know patients, nurses who are there 24/7, and not physicians. So how the idea, and this is something that I encountered in different contexts, that you get approval from physicians to do field work in a ward where it's actually nurses that you will mostly encounter, also speaks very much of the hierarchies of this space. I can't really make sense now of the inpatient outpatient thing yet, but the how, yeah.
Yeah, that is so true. And my assumption was that because in the outpatient department, it was more, it was patients who came in for mainly for follow-up, while the inpatient departments were patients who were living in the hospital for some time and patients with relatively critical condition. But yes, you make a very valid point, because in the observation during the 1 week that I sat in one of the inpatient wards, the doctors mainly came in 3 times a day, morning, afternoon, and then at night before they left, while the nurses were there constant throughout in different shifts.
I think yeah, sorry.
No, go for it.
No, it's, for me, it's interesting whom we consider as field workers, as researchers, as anthropologists, as those, as who is responsible to give me approval for my research. And I think because doctors in university clinics or physicians are also part of academia in a way, those are the people who might understand or see the benefit of research endeavors more pressingly than maybe nursing staff, who's just like don't have to follow, or many don't have to follow like an academic path that involves research, but how that is very much not in line with who's actually in the space. That was just an observation.
Yeah, that's true.
Yeah, no, but I just wanted to point out that right now nurses also follow academic path. So in the sense that is probably more about the hospital hierarchies itself rather than being part of the academia or not. Because right now, you know, nursing schools, and if we're talking about particularly like in the Nordic countries, sometimes are as powerful as medical departments. So I think it's still something about a hospital.
But also the academization of nursing. So this is very maybe more advanced in other countries. In Switzerland, it's still, I would say, in its, how do you say? There's like space to go.
Oben.
Yeah.
Yeah, ear up. No, but what I meant to say, and maybe this is a question for both of you. I'm actually kind of surprised about this discussion of the hierarchization. That's not a word, but you know what I mean. Of who do you ask for approval to do your research? Because I was thinking actually more along the lines of both for nurses and for doctors. I think there's been, at least in the context where I think, Julia, did your research, such a, administratization of both of those professions, especially doctors, but I think also nurses that just have to do a lot more admin work, that I thought that it would, maybe for both of your cases, would be much more asking administrative staff for the approval to do your research in hospital spaces, rather than, going specifically to one profession being doctors or one profession being nurses. And I was really surprised, Julia, in your case, that there were these, different parts of the one hospital that you were in, where in some you could do research and in some you couldn't. For example, you couldn't do research in the pharmacy, you just didn't hear back. But there was no kind of, higher up point of administration where you got the approval to just do research, in the hospital as a whole, if that makes sense. So I was a bit surprised that there was this, that you had these very different touch points within this, cosmos of the hospital that you had to get approval from. And I was wondering how that went for both of you. Similarly, maybe, but also differently, it sounds like.
Yeah, no, I have to quickly clarify. I did not get, for me, it was not getting approval from those sites, but getting appointments for like interviews to actually meet people. I had approval from that that made my access quite easy. I had approval from like the head of the medical director of the whole clinic to do this project. So I did not. I was, when I was approaching people, I was like, I'm doing this project for the medical collection of the clinic, and I'm backed by the head of the. Do you have time? And like it's about so I had that also facilitated access to people, because they were like, okay, if this got the okay from this person, then we don't have to like check again whether this is actually okay and who is actually this person. Yeah. So it was not getting approval from all those sides, but just getting an appointment.
Makes sense.
You want.
My case,
really interesting, because I think that would have said, something so interesting about hierarchies during the pandemic. If, for example, the pharmacy, the hospital pharmacy, out of all places, could have been in a position to say, okay, actually, you do have the approval from higher up, yet we're not participating in your research, for this reason or that. Okay, sorry.
In my case, it's very different. Disregard of the pandemic, whether there is a pandemic or not, it's very bureaucratized, very controlled. To do my field work on an infectious disease, I had to get ethics clearance from the Central Ethics Research Committee at the national level. To go into a public hospital under the Ministry of Health, I had to get ethics clearance from the Ministry of Health, from the Provincial Health Office, from the hospital, and after getting ethics clearance from the hospital, they told me which spaces were controlled by whom, and I had to approach the head of those spaces to ask for their approval for access, to be sitting in there. And then after spending time in there, then I would, have conversations with the healthcare workers and then ask them for their appointments. But everything was really strictly controlled.
Thank you. It's very interesting to hear how the access issue is coming up all the time, and it's always very different when it comes to different contexts. And And of course, it's very interesting to see also how the bureaucratization also mixed up with personal relationships. For example, like the way I encountered like the possibility to get access, I first approached the people in the emergency room, and they really wanted me there because they had to tackle the problem of overcrowding before the pandemic. So we're talking about 2017, 2018. And because of that, they actually were able to direct me to the hospital board in order to ask for ethical permissions. And when I asked for ethical permission to the ethical committee of the hospital, went on a regional level, and there were two different two different ethical board. And then I, of course, had also to have ethical permission in Sweden because I was coming from a Swedish university. So that was highly bureaucratized, but once I got the leverage from the emergency room, then I could go through the bureaucracy. Because without the leverage, I could have gotten the ethical vetting approved, but nobody was going to participate in my study anyway. So I kind of did the other way around. So.
No,
Interesting how
accessibility
these
to those
various
spaces is always,
yeah,
a story in itself. And yeah, for me, it was with this project very interesting to not have to foster, like I was not the person who was trying to get access, or I was, taking along, I was riding at someone's kind of influence, if you want so. But I have like now submitted a project as I mentioned, and depending on whether we get funding or not, I want to do research again in this site, but in a different role. And I would be very interesting to see how this is working out, because I know of projects at the University of Bern who really wanted to get access to the university clinic, and they didn't. So how, like, my personal connections to clinics and sites, and also the like previous experience might benefit me here. But how, those spaces, if they don't want you there, they're very, just impossible to get in. Hospital walls get very high and very thick.
So thank you again.
Sorry, I was just
Afaluk,
going to-
go ahead.
The rationale they gave me for these different ethics committee approvals required was because I'm not from a Thai university, although I'm a Thai national. So it's a foreign university studying Thailand.
Interesting also how national politics comes in. And it's also interesting because I was coming, for instance, like from an external university, so a Swedish university, and I wasn't asking for money to do the study, but everybody welcomed me in Italy instead. Because of, I was bringing money there. I was bringing research there without asking them for money. So, cost-free, then, I was welcome. So it's actually interesting to see, probably also the colonial heritage that maybe played a role. And of course, it's very interesting.
I have a question about the self-perception of Italy, because of Italy during the pandemic, or northern Italy, because here if like people in Switzerland and people in like engaged with in the clinic, also in the clinical context, usually refer to Italy as the example where we managed to not be as affected as northern Italy. And how did Switzerland manage to do that is always kind of the discussion. And it's always, it's never France. It's never other places, Spain, or it's always Italy. I mean, we share a border, but how the Italy is always used as a like one of the worst examples, if you want so. how is this in the how is that integrated, or how is this in Italy itself? Do you refer to other places as being worse off? Is the self-reflection of the pandemic and how it was kind of dealt with? Yeah, I would be curious to hear that.
I mean, I'll try to be very brief because this could be a seminar in itself, of course, and it's super interesting how things played out. And of course, I can really imagine that Switzerland refers to Italy when it comes to very bad results, because of course, if you just just look at sheer numbers, Bergamo and Brescia, and at the very beginning of the pandemic in certain places like Milan, Bergamo and Brescia in particular, were very, very had tremendous death rates, and the people in Bergamo and Brescia couldn't actually access ICU's care if they were older than 65 years old because they simply didn't make it to the triage cut. So they just, weren't even intubated, or they didn't even try. Because of course, the rest were so dire that they had to make choices. And yes, so at the very beginning of the pandemic, so after the first wave and all this messiness that hit immediately northern Italy, it was developing a narrative about the fact that 20 years of privatization and austerity have left a mark upon the Italian service, and that's the result, the direct result of what happened. Because also Lombardy is the most highly privatized healthcare when it comes to Italy, because Italy, when it comes to healthcare, is really much divided into regions. The region you go is basically almost like changing state. So there are different systems in place. And Lombardy is the highest, the most privatized place that you can actually come across in Italy. And that was also the highest amount of death rates. But that was actually weaponized back. So nowadays, we actually see private enterprises from insurances to private hospitals and so on and so forth, using the same narrative against the public system itself and saying, look at what the public system have done during the pandemic. You know why it's so shitty? Because we don't have enough private hospitals. So we should actually build another pillar of privatization and so on and so forth to make it better, because they cannot afford, or they cannot manage to actually defend us from the pandemic. So imagine if it comes another pandemic, what will happen? So it's interesting how this narrative can be kind of back and forward from these two different poles. So highly privatizing the healthcare system, or try to give back funding to the public system. And when it comes to outcomes in Europe, probably Italy has had the worst outcomes, but also heavily underfinanced, and at the same time also was the first country hit by the pandemic in Europe. And what it was interesting is also that it took like one of the most densely populated areas with one of the most densely privatized areas when it comes to services and lack of welfare. So it was kind of the perfect storm. It was really the perfect storm.
But this is, yeah, and this is really interesting. And as you said, like in the beginning, you had the worst numbers, because if I remember correctly, Switzerland was very, very like there were a lot of deaths during the second wave, and nobody talked about that. And this was also due to opening, like everything was opening up, no lockdown measures anymore, and like death skyrocketed, and nobody talked about that. And yet there you have not so much like the argument of the economy. Switzerland has to, like, we can't afford more lockdown measures, etc. We have to like have restaurants open, etc. That was driving those decisions, and that, yeah, if you want, so also caused the deaths of many, but yeah, there's no space to talk about that. This is something that is mentioned in a side note.
Yeah.
And so also how the perception of the Italy's worse off at what point in during
Sure.
the pandemic. Yeah.
Yeah.
Thank
So
you.
are there, thank you. And are there any other questions? Okay. So thank you everyone for a lively discussion today. And thank you so much again, Avaluk and Julia, for your presentation. And it was really great to see how your two cases and analysis actually talked with each other, even though having a different context and different, focusing on different diseases. It was interesting to see how objects and materialities really came to life through your discussion as well. So thank you again.
Thank you.
Thank you.
Thank you.
So much, both of you.
Thank you.
See you at the next one.
Thank
Bye
you.
bye.
Bye.